women generally live longer than men. Women have a longer period in general of a hormone drought. So if you live to be 80 and your menopause is complete by 50, that's 30 years that you may be living in no man's land in terms of not having adequate hormones.
So welcome back, Susan. I have really nice comments under the last episodes that we did between you and I. My audiences are really flattering you, and they're like, I wish that we had a Susan in Turkey as well. And I'm like, well, believe me, I want to clone her. But in any event, welcome back. Today's subject is very important to me, like many subjects, but as you know, I did struggle with it. I'm in my menopause now, and I really wanted to dive deep into this hormone replacement therapy and why it's needed, why people are afraid, what happened in the past, what can change in the future. I want to really dissect all these wonders and questions. Our audience can also read some articles that we publish in longevitylab.com if they want deeper dive into this topic. But let me start with the first question that I'm really curious about. Many people, different age groups, let's say, there's this, at least in Turkey, I didn't talk to many people about this subject in the United States while I was there, but over here I have many more women around me. My aunt, my mother, my sister, my friends, so many women. And it's always a conversation, this whole hormone thing. People, let's say my mother's age. I don't want to disclose your age, but you guys are close to each other, like a couple of years apart. What happened since then to now that there's a big emphasis on replacing the hormones that we women are losing after our menopause, premenopause? And with that question, I want to add also one other part that when you give your answer, you can give a bigger answer. Why at some point people were giving hormones and then suddenly there was this scare of, oh my God, it may cause cancer, so let's stop everything. So let's start with this. The stage is yours.
Good question, good series of questions, because this has been one of the real challenges, and for me personally, one of the big frustrations with medicine and medical research. So for many years, the primary research subject for a new medicine, a new treatment, a new evaluation of a product for healthcare has always been men. They were always afraid to use women in their menstruating years or their childbearing years because of a real concern, which is that you might be pregnant. And then what is the impact of this unknown medication or treatment on an unborn fetus? So they just said, nope, we're not using women. So much of medicine, many of the medications that we have even today are tested on men and yet prescribed for women as though we are exactly the same. And biochemically, we are not. So there was a long period of time when there just wasn't research done, or they were naturalistic studies, just following women through their lifetime to see what was happening. As women began to age longer, as we developed the birth control pill, which was a dramatic change because now women have more control over their fertility, of when they're going to have a baby or not. They began to test these medications that contained estrogens or sometimes progestins. Now, I'm using the word progestin purposefully here because these medications that are in birth control pills are not bioidentical. They're synthetic hormones, some of them derived from androgens or male hormones. They started using birth control pills, and we began to see some side effects, some problems, particularly women who smoke were now at risk for blood clots because estrogen has many effects, but also on blood flow and on our blood vessel size. So they started to see some problems. Then as they studied these more and more and fine-tuned to get lower levels of the lowest level of the hormone that would be effective to prevent the pregnancy, prevent the woman from having periods or decrease their periods or treat acne or painful periods, birth control pills were more and more widely used. But also now, as we are older and women do not want to go to the nursing home and sit in the corner, they want to have active, healthy lives. But menopause really throws a woman into a very significant metabolic, physical, psychological, emotional changes. They began to research more and more, what can we do to treat women in this phase of our lives? We're much more complicated than men. Our hormones are so complicated. Treating women is much more difficult because of the fluctuations over the life cycle of hormones. But they were using the synthetic hormones. They were using progestins and synthetic estrogen. As they followed some of these women, and again, they didn't use women in premenopause or early menopause. They used women and gave them hormones after they were in menopause
Mm.
because they didn't want to risk, again, the possibility that the woman could get pregnant, and now we've got this complication of we're giving these hormones to a woman who may be pregnant, and what's that impact on the baby? So they used postmenopausal women. And what they found is that there's actually, for some of these synthetic hormones, increased risk of heart attacks and increased risk of breast cancer. So then suddenly this move to let's treat menopause, let's relieve women of all of these menopausal symptoms, there was a hard stop for a lot of people. And many doctors and many patients said, oh, I'm not going to risk a heart attack. I'm not going to risk a stroke. I don't want to risk breast cancer. I'm not taking these hormones.
Would it be different if they would start women in their premenopausal phase?
That's what the recent studies are showing. The recent studies over the last 10 to 15 years are showing that if we begin to monitor a woman's hormones in her 40s and begin to subtly replace, not block those hormones, but subtly keep the hormone level pretty steady as their ovaries give out and they produce less estrogen and progesterone, we'll slowly replace them, and we will give them bioidentical. We will give them hormones that their body recognizes, knows, doesn't have to convert to something else, doesn't have to limp along and make do. This is basically the very same hormone, and keep those levels steady. As your hormones drop down, we replace. And what we're seeing is that these risks of cardiovascular disease, these risks of breast cancer, there are still some because we can't change the person's fundamental genetics. If you have strong genetics for heart disease, or if you have the BRCA gene, other kinds of things that make you at risk for breast cancer, we're not changing those, but we're not seeing an increased risk. In fact, we're seeing better health. We're seeing decreased risk of things like dementia and other improvements in quality of health and quality of life.
Mhm. Before going there, you said that this whole thing, it started with the birth control pills and the type of hormones they were using there. Then they started to apply to postmenopausal women. So this synthetic hormones, androgens.
They're modified androgens, many of them. Some of them are purely synthetic.
Yeah. So what I thought I heard is that because one, they were synthetics and they started after a certain period instead of slowly making them start, that has some adverse reaction. So let's first ask about the synthetic ones. Would it be different if these synthetic ones would be introduced to people's life on their premenopause, or would it be the same disaster, catastrophe?
Well, they're still looking at that now, and many of the research, at least here in the United States, is funded by the pharmaceutical companies. So the pharmaceutical companies are very interested in the synthetics because it's much more complicated to get patents on more naturally occurring substances like natural vitamins or natural hormones. So there's still some looking at these synthetics versus the bioidentical hormones. And so there are some studies being done in this arena to see, is there a difference? Do we need to worry about a synthetic hormone versus a bioidentical? I have not seen any definitive study about that, but they're also looking at hormones in the perimenopausal period, this where you're still potentially having periods, but they may not be as regular. You may start to have some of the subtle symptoms of menopause, but they're not severe and they're not all the time. So during this period of time, the studies are now being done looking at the bioidentical and the longer term outcomes. But remember, to study for 20 years, that's a long study, and that's a very expensive study.
Mm-hmm.
And it's hard to do a blinded or placebo control. So because of that, the expense and the challenges of studying somebody over 20 or 30 years, they're looking more at observational studies where this group of women already is on the bioidentical. This group of women may already be on the synthetic. And comparing those outcomes over 20 years takes a long time. So those studies are not complete, but sometimes then they can see a difference and they will halt the study, seeing that clearly one arm of the study is more effective or causing less side effects or bad outcomes. So those studies are being done, thank goodness, but it's going to be a minute before we have some of those results.
So what then happened that the medical field started or decided to restart using them? So there were the synthetic ones. They saw that there were some heart issues, cancer, whatnot. They had a heart stop. Then someday, suddenly, they started, hey, let's try that again. How did it all started?
There were some doctors that stopped prescribing. There were some patients that said, I don't care, I'm not taking them. It wasn't as though they stopped being manufactured or they stopped being used, but there was definitely a slowdown with functional medicine, with people looking at preventing diseases as opposed to treating the disease now that it's here, which is kind of that difference. Because once you're full tilt in menopause, then that's a different treatment because you've already got the symptoms, as opposed to let's monitor and let's begin to supplement gradually to mitigate or minimize or even eliminate the symptoms of menopause at all and just ease the woman into that transition, increasing her hormones to make up for the difference of the ones that she's no longer able to manufacture by her body. So as we started to see more functional medicine, more people interested in trying to improve function as opposed to treat disease, we're seeing the shift to bioidentical. We're also seeing the shift to treating and prevention of the symptoms of menopause. We can't prevent menopause. Your ovaries will give out, but what we can see is that we are replacing the hormone as your body can no longer manufacture it. So you're easing into a transitional phase, but having few symptoms.
Okay, then you already came to the part that I want to ask you because as you know, from A4M, I took a couple of courses, and one was about the hormones. And that was the time that I started the first phase of my premenopausal or premenopausal treatment. So I was really curious about it. And the amount of functions that these hormones are doing in our body are like, it blew my mind. And not only estrogen, because I'm pretty sure if I go outside now and grab 10 women, they would know what estrogen is. They would know the progesterone. But I'm sure that they have no idea that they have testosterone. Because it's kind of like, the pink and the blue in the outfits of the girl and the boy. So testosterone belongs to the man and estrogen belongs to the women. So let's please start with estrogen, then go to progesterone and then testosterone for women. What are these crucial functions starting the premenopausal phase? We women start losing these functions or malfunctioning outcomes.
So you've brought up a really important point, Esra, which is that men and women have the exact same hormones. Men have estrogen, women have testosterone. The difference is in the organ that makes it and in the amounts. But it is really important for us throughout our life to have the proper balance and the proper type of hormone. So even before we're born, in order for our mother to be able to maintain that pregnancy, the placenta and the uterus and the ovaries are making estrogen and progesterone to keep the pregnancy viable. And a certain type of estrogen called estriol actually works on our mucous membranes, our eyes, and our vaginal area to help prepare the body for birth. The hormones are also active in the baby to develop the secondary sexual characteristics. Are you going to develop ovaries and a vagina, or are you going to develop testes and a penis and testicles? So how is this going to be is determined by what our hormones are even before we're born. Once we're born, our individual hormones stay pretty docile. We don't really have a lot of fluctuation with hormones until we hit puberty. And then, oh my goodness, estrogen at that point becomes very apparent. We develop secondary sexual characteristics. We develop breasts. We get more curvy. Our shoulders don't broaden. Testosterone does for male. Our shoulders stay narrow. Our hips may enlarge. Our ratio of body fat to muscle is different. We grow body hair. And we have the capacity shortly thereafter to actually become pregnant. For the men, the testosterone picks up and it carries on, and testosterone for men stays pretty dominant through their life. They don't have the fluctuations with the periods and so forth. But testosterone is also really important for women. We need it to be able to develop muscles. We need testosterone to have strong bones, just like we need estrogen. They both help. And we need testosterone to be able to have an organ, which is really important for both men and women. So sexual functioning is regulated for women by having a little bit of testosterone and another hormone made by our adrenal glands called DHEA, dihydroepiandrosterone. So DHEA is much easier. So that's responsible. It's made by our adrenal glands for both men and women, the little organs that sit on top of our kidneys. And it is really important for desire, not the ability to have an orgasm, but the desire to have relations with your loved one, and also for how quickly your brain processes information. All of these hormones have impact on brain and body. But women have to have estrogen. Men have to have estrogen. It's very important for them in terms of cognitive function, memory. If they have too low estrogen or too high of estrogen, that's going to result in men having sexual dysfunction. Maybe they don't have the ability to have a complete or full erection because they've got estrogen imbalance. So we don't usually think about women having testosterone or men having estrogen, but it's very important for both of us throughout our life cycle.
Then let's come to through our life cycle, and let's say for women it starts earlier with the premenopause, and then these hormones starts dropping. If we don't replace, let's say, if we don't replace, what are the consequences?
If we don't replace, there are a number of consequences.
Mm-hmm.
So, first of all, you have this drop in estrogen, which is, processes different for different women, but it begins in the early 40s,
Mm-hmm.
early to mid 40s, and by late 40s, early 50s, most women are fully into menopause. Their ovaries have ceased making estrogen. Fat cells may still be making a little bit, adrenal glands may still be making a little bit, but you've had a dramatic decrease. And what is going to happen then is that you are going to have hot flashes. So this is where your autonomic nervous system is all out of whack because estrogen kind of keeps it regulated. So you'll have this sudden burst of heat literally from inside your body. Your hair may get wet and sweat, your body sweats. It's very disruptive to sleep. With lack of estrogen, you now find that your eyes may be drier, that your mouth may be drier, that your vaginal area may be drier, and it may be actually painful to have intercourse during this period of time. You start to lose collagen in your skin, and so you begin to see the fine wrinkles start, followed by some pretty major wrinkles. You begin to now have the risk of more brittle bones. Estrogen is really important for bone health to make sure that we have really good, strong, healthy bones. And so that begins to happen. We see impact on memory and cognitive functioning, the ability to concentrate. Women will describe just having a really foggy brain. They also begin to not find as much joy and satisfaction in things that normally bring them pleasure and make them feel good. Sometimes they get even depressed. Now, you have to be careful because depression isn't necessarily a symptom of menopause. That person may have clinical depression requiring different treatment, but it's really important to look at this. So the whole body just begins to not function nearly as well as it did when we had our full complement of estrogen and then progesterone.
We dive deep into the estrogen, but what happens when there's no testosterone? There's the other hormones, the HCA, testosterone, progesterone. What I noticed actually, most doctors are prescribing estrogen nowadays, but I don't hear the rest of the hormones that they suggest to their patients to take.
And that is very true. And what does testosterone do for men and women? Strong bones, of course. The ability to have an orgasm for men and women, testosterone mediates that. So when women begin to have difficulty or may not have ever had a satisfying orgasm, one of the things that I would check would be, do you have enough testosterone? How is that? Is that part of the impact? Now, there may be psychological reasons, there may be a variety of other medications impacting that, but it's something to look at. But more importantly, testosterone provides for both men and women a sense of self-confidence, a sense of well-being, a sense of just being okay in your own skin, kind of a calm peacefulness. Too much testosterone or too little testosterone can result in, for both men and women, irritability, self-doubt, difficulty with decision making. You can see all kinds of more subtle, maybe psychological impact of low testosterone, again, in both men and women. So if a man comes into me with symptoms of depression, yeah, they may have a genetically inherited depressive disorder. They may have a reactive depression from grief or loss, and they may have low testosterone. And so I'm always going to check those in both men and women showing up with symptoms of depression. Might not be the problem at all, but very often it is. And very often a little bit of management of their hormones can go a long way to helping them feel better.
And probably muscle mass.
Muscle mass and endurance, the ability to have capacity to exercise and the motivation to exercise, and then the ability to see the results from the exercise. The definition of muscles, the building of muscles, and the ability to lose body fat.
That brings me this question because I hear also from friends that when their husband or boyfriend, I'm not talking about Turkey, in America, let's say, they're put on testosterone, suddenly the character changes. The guy becomes someone that is too self-confident, a little cocky.
Right, aggressive.
Aggressive in a way. And therefore, women are afraid of their men to go on testosterone. And with that said, this question came up to my mind for women and for men, because obviously for women, they were afraid of the possible cancer reaction, and men, the other behavioral or thinking problems, let's say. So, when would we need to measure our baseline so that there would be a better substitution to these hormones? It makes me think, like, if they know what the real amount should be for that person, and if you supplement that, then you wouldn't face these other problems. Does that make sense?
Absolutely does, because what my lifetime estrogen levels are, what's comfortable for my body, my brain, may be very different than what yours are. And so having some studies done, now it's trickier with women than men because men are going to have pretty much the same level all the time. With women, we have fluctuations throughout our menstrual cycle. But knowing your menstrual cycle, knowing the day of your cycle, and having hormone levels done will help you understand, are you someone that without symptoms? Now, this isn't if you're having trouble with anorexia, or you're having trouble with polycystic ovarian disease, or you're having issues with heavy periods or no period. But I'm talking when you're having a normal cycle for you and you feel physiologically stable. Get your hormone levels done then. And that can be a good marker for you as you move through this transition in your life for when you need to have hormones and at what level they need to be replaced. Does that make sense?
Yeah, that makes
So
perfect
I think
sense.
that's really important.
So let's now then come to what I experienced. And it was really painful, psychologically painful. It wasn't painful literally. There was this period of time that when I was taking these hormones, replacing these hormones, I did put on a couple of kilos. I had cellulite. I really was very unhappy with my life, and I was so ready to drop them all. Like I said, like, I don't care. I mean, I'm very, very, very miserable. Then I heard that I'm not alone. I had, a beautiful, beautiful friend of ours that she was put on hormones when she visited Los Angeles. She started putting weight on, and she goes like, I don't care about the wrinkles and whatnot. I prefer to fit into my outfits than taking these hormones. And I hear from so many people, honestly, they say, like, I prefer to look as good as I can, as long as I can, instead of dealing with these weight issues. As you can understand, this for women, weight is the most important issues. It's like an internal comfort and exterior comfort at the same time. Let's put aside, like, you need to buy new clothes. So what happens then, that, like, how long people need to buckle up to pass through these periods of weight fluctuation, and also, like you guys did to me, with a deep dive into testing, and we supported with different supplements as well. But please explain what happens then, and how long people need to be strong not to give up.
And be patient. So this is where medicine is more of an art than a science. When we have someone who we begin to see is going through menopause, perimenopausal, we as physicians make our best judgment about what is a good source of estrogen. Are you going to use cream? Are you going to use estrogen that's absorbed through the vagina? Are you going to use a patch? Are you going to swallow it by mouth, which I do not recommend, the estrogen not by mouth. But there are a number of different delivery methods. There's a number of different dosing schedules. Sometimes women will get estrogen pellets placed in the deep tissues in their buttocks so that there's a continuous release of estrogen. So there's lots of different ways and lots of different doses. And you try your best to make sure that you start low and slow and you see how the person reacts. You also have to look at the other hormones. They have to be in balance. So if you get too much estrogen, you're going to have some issues. If you get too much progesterone, you're going to have some issues. If the testosterone is not adequately balanced, you're going to have some issues. So you've got lots of moving parts, and the woman has been going through months to maybe years of lower estrogen, and now you give them some estrogen replacement, and they may have some of these reactions like weight gain, increased breast size, increased hips. Remember what happened back in puberty when you went from 0 estrogen to, wow, suddenly you're a girl almost overnight. And you see that impact. Estradiol, E2, that's the most potent estrogen. That's the one most women have throughout their lives. That's the estrogen that most men have. There are other forms of estrogen, but this is a potent medication. And so you try it, the body begins to respond. Sometimes it over responds. Sometimes it doesn't respond enough. Sometimes there are other side effects that happen. So this is where it's very frustrating because you have to see your doctor really regularly. You need to do different tests. So before menopause and before any hormone treatment, you can get blood work done. We can draw your blood and we can see what are your hormone levels. Once you go on replacement, it becomes more complicated because what's circulating in your blood may not be what's inside your cells. So then we have to do saliva testing, which is sometimes very complicated and sometimes not available. So you do the best you can, but they're going to be maybe 6 months to a year. Sorry, but it may take that long to get all of the hormones regulated and in balance for you. The more you know about your pre-menopause levels of hormones, the better target we have, but it still may take some time to find out, oh, you may need topical cream, you may need patches, you may need an estrogen troche, you may need estrogen pellets. We need to find not only the right dose, but the best delivery method for you. So it is frustrating, and I wish someday we'll have a more exact science. We don't right now, so there's a lot of art that goes into this, and a lot of patience required, unfortunately, on the part of the woman as she's going through getting settled.
Maybe 10 minutes ago or so, you mentioned about how it helps the brain to work, estrogen, like the memory and so on. In one of the latest podcasts that I was listening with this Italian scientist, knowing that your expertise also is with the brain. And I didn't know up until then that people who get Alzheimer's disease, 2/3 of them are women. It's not the only reason, the lack of estrogen after menopause. Obviously, there are so many different moving parts, but one of the very significant changes they see that the sudden drop at an early age, meaning compared to men hormone changes later on than women, and most women by around their 50s, the estrogen drop. And if they don't support their estrogen level, probably they would face more brain deterioration. What do you think?
I think that's very true. And I think that it's also important for men. But to your point, women generally live longer than men. Women have a longer period in general of a hormone drought. So if you live to be 80 and your menopause is complete by 50, that's 30 years that you may be living in no man's land in terms of not having adequate hormones. And remember, one of the first things that people begin to complain about is foggy brain. I can't concentrate, I can't remember. Estrogen's really important for the hippocampus, which is our memory center of our brain. May I share a story with you that's close to my heart?
Of course, please.
So my mother had 4 children, a complicated last pregnancy that resulted, she was 26 years old, and the doctors at that time said, we're just going to take out your uterus and your ovaries. So at 26, they took away the vast majority of her hormones. Over the years, she struggled so much. She was 6 feet tall. When she and my father got married, she was actually a little bit taller than he was. She began to have compression fractures in her spine at an early age because she had no hormones and no hormone replacement. We lived in a small town. There weren't a lot of OBGYNs around. Nobody thought about this. She had early menopause, all of the symptoms, severe depression, lots of difficulty through her life. She shrunk about 4 inches, had tremendous back pain her whole life. And then fairly early, she began to develop dementia. She was a bright woman, a very talented musician, very outgoing, gregarious. People loved her. She was a lot of fun. But as she got older and early, she began to have serious decline, became very withdrawn, and had serious dementia. So she lived her life in pain from lack of bones because no hormones. She had bouts of depression that were severe, and then she had dementia. And to my thinking, sitting here today, if they would have replaced her hormones, whatever the reason was that and I was only 6, so I wasn't in on the conversations, but whatever the reason was, they decided to take her ovaries and not replace, they just didn't do it. They didn't treat menopause back then. They didn't recognize that here's this 26-year-old woman with 4 little children who now has 0 estrogen, progesterone, and it is in a mess. So that is a dramatic story, but one that really tells you she had hypertension uncontrolled. She had elevated lipids. She had diabetes. She had lots of physical symptoms that, in my mind, very likely could have been eliminated, if not managed better, if she'd been on hormone replacement.
That's a very touching story that, if anything, people need to hear these personal and true stories to understand what it could be if it was treated differently. That was very, very important. One last subject matter that I want to touch base on is on men. Not only at their later age, because I know through a person that is close to me that he was demonstrating a low testosterone and had nothing to do with his sexual capacity or ability, but he was demonstrating other symptoms such as agitation, tiredness, and so on and so forth. 2 questions. One is, what happens if you're in your 40s and so on, you're very healthy, 35, 40, you're very healthy. Why would testosterone get lower? I don't want to say totally low, but gets lower. And what would be the symptoms that comes with it?
So that's a very good question. In my patient population, since the majority of my patients have the disease of addiction, the actual use of drugs and alcohol have a big impact on hormone levels for both men and women. And when I see a lot of my patients, I do get hormone levels on everybody, thyroid, adrenals, ovaries, or the testes, to make sure that some of the symptoms they're having are not caused by, or at least contributed to by, inadequate hormones. And this is a theory, so hopefully I'll be disproven. But when you start to see men in their 40s and 50s going through the midlife crisis, I suspect that it is because they too are starting to see a gradual decrease in their testosterone level. And if you look at the charts of what's supposed to be normal testosterone levels through the ages, we see that into their 30s, their levels should be somewhere between 800 and 1,000. That's a usual level for a man. But as they get older, now we're getting into the 500s, the 400s, the 300s, and by the time they're getting in their 70s and 80s, they've got really low testosterone. Again, thinking about what testosterone does for men and women, it's part of that self-confidence, that sense of well-being, that feeling like I can manage my life, whatever comes, I'll figure it out. It'll be okay. I may not like it, but I can figure it out. As the testosterone starts to drop, I think that it has an impact on self-esteem. And again, testosterone is the major hormone for men. And as that begins to drop, they begin to doubt, they begin to have more trouble with sleeping, they may be gaining some weight, which always makes me think testosterone's dropping, estrogen may be rising for them. Their sex drive changes. Now they got to go out and prove that they're the guy. And so they kind of lose their mind a little bit and start buying cars and having affairs and changing jobs and getting divorced. I'm not saying that's all testosterone, and, I'm sure there'll be many comments coming, but it would be one thing to think about in looking at, has your testosterone dropped? Do you smoke? Do you use pot? Do you drink alcohol? And I don't mean addictively that you need to come see me, but I mean those particular substances take a toll on the hormones. What is your diet? Many people are going to plant-based diets, and in many ways that can be really healthy. But soy, good protein, inexpensive protein in a lot of things, added to a lot of protein shakes and bars that men consume. Soy takes testosterone and converts it to estrogen. So it's actually depleting their testosterone. So there are many things that can be contributing to it. Much of it is lifestyle. Some of it may be substances. Some of it may actually be other genetic problems or issues with their testosterone itself.
Also like some energy levels and foggy brain and etc. as well. That's what I was seeing as a case. So what I'm hearing from you is like people who are strong meaning a strong mindset, let's say, and the willpower of muscling it through, even
Right.
though they're not using hormones, such as my mother. I mean, my mom. And I see like, she loves life and she wants to make the best out of it. She's well educated. She reads her books and whatnot. She owns an art gallery. She walks around to point A to point B. Therefore, even though she's not using hormones, she's not replacing her hormones, she still can have some sort of a drive in life because she is
Yeah.
doing so many external stimuli to at least counterbalance these negative effects. And obviously, she has good genes, and I'm lucky that I'm her daughter. But when we see people who are suddenly in decrease of energy and memory and lack of desire of socializing and miserable in life, men or women, because they don't support their hormones and they don't have that much of a willpower to fight with life, then their decline is much faster. The reason I'm saying this, because I can almost hear many people saying, oh, well, my life is not that bad that like you guys are describing. So these people still have a drive to make their life better. But the minute that the life stops and your hormones drop, then your system declines like incredibly.
I'm not saying that anybody who has a midlife crisis or anybody who is depressed or struggling, fix your hormones and you'll be fine. What I am saying, though, is that hormones need to be part of what we call the differential diagnosis. You hear a patient's symptoms and you start thinking, could it be this? Could it be this? Could it be this? I want people to also be thinking, could this be hormone? Could it be thyroid? Could it be major depressive disorder? Could it be cancer? All of those things are possible. They have many overlaps in terms of symptoms, but the idea being, think about your hormones too. Ask your doctor about your hormones too. Make sure that you are thinking about that and asking about that. Hormones aren't everything. They aren't the only thing. And some people can't take hormones even if it's very clear that they're lacking them because of other risk factors. But always think about, is this possible? Lifestyle is our most powerful predictor of good health and good cognitive processes. Exercise, eating well, avoiding sugar, avoiding substances, taking good care of yourself, getting good sleep, all of these things can help you live longer and healthier. But if you begin to start to see some declines in areas in spite of your best efforts, please think hormones and at least get them checked.
Susan, thank you again. This was a wonderful episode. We covered everything about the hormones that I wanted to spread as a message. I'm a firm believer. And I know that you would like to share something.
So I would like to remind the listeners that this is for educational purposes only. This is not a substitute for seeing your doctor. This is not meant to give medical care. But what I hope that this episode and the other episodes that you're doing, Esra, is to educate people, help them to think, make good decisions, and to know what questions to ask their doctors.
Thank you so much. Thank you for your time, and I'll talk to you soon.
Thank you. I appreciate it.